done with the antifungal agents, and we have seen various classification of antifungal. In that we have discussed about amphotericin B, 5-fluorocytosine, and we have also discussed about azoles. But I'm just going again quickly through the azoles, where there are two classes. One is imidazole, another is a triazole. As I already told you, imidazoles came into the market first because they were associated with certain side effects. The second category of the drug which came was triazole, which included drugs like Itraconazole, Fluconazole, Variconazole, and Socanazole. Regarding the mechanism of action of azoles, they are known to inhibit fungal cytochrome P453 enzyme, lanosin 14 alpha demethylase. Now, what is the role of this enzyme? This enzyme is one of the intermediate enzyme involved in conversion of squalene to ergosterol. Students, do you remember ergosterol, which is an important component of the fungal cell wall? Now, if this enzyme is getting inhibited, there won't be a proper synthesis of the ergosterol in the cell wall, and that will lead to the destruction of the cell wall, ultimately causing the death of the fungi. So all these drugs act as a fungicidal. Okay, they will interfere with the synthesis of the cell wall. Now here are the various types of the azole derivatives, including ketoconazole, itraconazole, fluconazole, then variconazole, and socanazole. There are various types of the drugs: ketoconazole, itraconazole, fluconazole, variconazole, and soconazole. I have already discussed with you various important pharmacokinetics of this drug. If you remember, and if you revise, that itraconazole has a T-half, which is the longest T-half, 24 to 42 hours. Fluconazole is the only drug which gets excreted through the renal route, whereas all other drugs are getting excreted through the hepatic route. And fluconazole is a drug which can show a very high CSF concentration, and therefore it can be used for treatment of certain fungal infections which are associated with CSF. Azoles are known for their broad spectrum activity. They are effective against candidal infection, cryptococcal infection, blastomycus infection, histoplasma, coccidioids, and dermatophytic infection also. Amphotericin and 5-fluorocytosine, which we have already learned, were not having a very broad spectrum of the activity. But azoles have a very broad spectrum of the activity. They are effective against lot of types of fungal infection, and therefore you can see that they are very well established into the market as an antifungal drug. And even there is an added point why they have been accepted so nicely by the physicians or the clinicians to treat fungal infection is because they are relatively non-toxic as compared to amphotericin and 5-fluorouracil or cytosine derivative. Because they also have a minor GIT side effects. Yeah, they cause inhibition of the cytochrome P450 enzyme, and therefore sometimes there may be abnormalities in the liver enzyme, and there can be a lot of drug interaction, because we know that this 450 enzyme is involved in the oxidative metabolism of various drugs, and azoles are inhibiting this enzyme. So they may interfere with metabolism of some other drugs, so they may be associated with lot of drug interaction. So as a pharmacologist, you have to remember that when you are administering azoles to the patient, or when you are dispensing azoles to the patient, you have to keep it in the mind to warn the patient about the possible drug interaction. They rarely cause a clinical hepatitis, and that's the reason why they have been widely established as antifungal drugs. So these are the important points. Now we will see the individual azoles. In that, the first individual azole is ketoconazole, which is the oldest but the toxic azole, which was then replaced by the itraconazole. But it is because why ketoconazole is still surviving in the market? Because it is less costly. So in the developing countries, it will be more accepted because it has a broad spectrum and it is comparatively less costly. It was actually the first oral broad spectrum azole which was introduced into the market for clinical use. It has a less selectivity to the fungal P450. What is the meaning of that? It will not only selectively inhibit fungal P450 cytochrome enzyme, but it will also have an effect over the host, that is a human P450 enzyme also. It has a variable kinetic properties also. It shows a variable absorption. It gets maximally absorbed when the pH is acidic. Now this gives a warning that patient should not take ketoconazole along with antacids or the drugs inhibiting acid secretion like omeprazole or the drugs which are reducing acid secretion like ranitidine or cimetidine, because these drugs will increase the pH. They will shift the pH towards the alkaline side. And if the ketoconazole is administered, its absorption will be hampered because it gets better absorbed only in the acidic media. So this drug interaction, you have to remember that ketoconazole cannot be administered with a drug which reduces hydrochloric acid secretion in GIT. It has a penetration in the brain, but its availability in the CSF is poor. In high doses, it inhibits adrenocorticosteroidal hormone, and it also inhibits testosterone synthesis and may lead to the condition like gynecomastia, which is dangerous in case of the male patient. So again, there is another warning which comes for the ketoconazole. It is more soluble at a lower pH and therefore its maximum absorption takes place in acidic pH. It gets bound largely to the albumin and the RBCs. If you look at its T half is only, you can say, is ranging between the 11 to 6 hours. Poor penetration in the CNS and hence cannot be used for fungal meningitis. And it can achieve a very good concentration in the skin and in the vaginal mucosa. So it can be used for treatment of the dermatic fungal infection or the infections which are associated with the genital organs. The adverse effects are, there is a decrease in the androgen production, which I already told you. It inhibits the testosterone from its binding site and therefore it may cause libido type of adverse effect. It even interferes with the synthesis of a female sex hormone, that is estradiol, and sometimes in ladies consuming ketoconazole, menstrual abnormalities may be observed, and it is also contraindicated in nursing ladies, which are lactating ladies, or in the pregnant ladies. It cannot be taken by the pregnant ladies because it will interfere with the organogenesis of a fetus. As I already told you, because it is inhibiting cytochrome P450 enzyme, and that enzyme is involved in our human body for metabolism of various types of the drugs. So there are going to be a lot of drug interaction. As rifampicin and phenytoin, they will decrease the ketoconazole level because both of them are known to be inducer of the cytochrome 450. Ketoconazole increases cyclosporin, warfarin, estimazole, corticosteroidal, and theophylline level, because all these drugs in the body get metabolized by cytochrome P450 enzyme. But in presence of ketoconazole, this enzyme will be inhibited. And that's the reason why their plasma levels in the body will increase. Many of these drug interactions may sometimes prove to be severe. For example, if the warfarin level in the body increases because of the inhibition of cytochrome caused by ketoconazole, warfarin is an anticoagulant drug. And if its level in the body are increased, they may lead to the internal bleeding, which is very dangerous for the life of patient. So these drug interactions have to be remembered by pharmacists, and when he is handing over such type of the drugs to the patient, he has to warn the patient about possible drug interaction. Even the drugs which increases the gastric pH will decrease the absorption of ketoconazole, and patient will not get benefited even after consumption of a ketoconazole. So the second warning is that ketoconazole should not be administered with antacid, omeprazole, or H2 blockers. All three categories of the drug inhibit acid secretion. So they may interfere with absorption of a ketoconazole. Students, please remember this drug interaction, as there can be short questions asked on such type of a drug interaction. Itraconazole is another azole derivative, which is again a broad spectrum antifungal. It has a fungistatic action. It inhibits the synthesis of a fungal ergosterol similar to the other azoles. But its absorption gets increased if this drug is taken up along with the food And also similar to ketoconazole, its absorption is maximum at a low gastric pH. Its penetration in the brain is there, but CSF concentration is less. What is the difference between ketoconazole and itraconazole is that ketoconazole was not specifically inhibiting P450 enzyme, whereas itraconazole specifically inhibits P450 fungal enzyme. And that's the reason the number of the drug interactions reduces. Now it is active against the range of dermatophytes. If it is given orally, it shows variable concentration, but it is highly lipid soluble, and therefore sometimes it is inserted into the pockets of beta cyclodextrin to administer it by intravenous route so that to avoid its variable oral absorption. So in emergency situation where you have to give itraconazole, and if it is given orally and showing variable absorption, the only ultimate route which remains, which is left is intravenous. So in such situation, when you have to give a drug intravenously, it is given as inserted in the pockets of beta cyclodextrin so that there won't be a variable absorption. Its T-half is longer than that of the ketoconazole, 36 hours, and it gets excreted in urine and does not penetrate into CSF. The next drug which comes under this category is fluconazole. The fluconazole has a broad spectrum fungicidal activity. It is effective against some gram-positive bacteria also. So here you can see, as compared to itraconazole and fluconazole, you can see fluconazole has a broad spectrum activity not only against the fungi, but this drug will be also effective against certain anaerobic bacterial and that to gram-positive infection of the bacteria also. So it is active against both bacterial as well as the fungal infection. Even ketoconazole and itraconazole was showing a variable absorption, but if you see fluconazole, it shows 94% of the absorption, where there is a very good absorption of the drug. Even the penetration in the CNS as well as the CSF is good, and therefore this is a drug of the choice for cryptococcal meningitis. So that outstands the fluconazole from the other type of the azoles. Let's move on to the another drug, that is a seconazole. This is the newest triazole derivative. It has the broadest spectrum of the activity, and it is the only only azole out of all azoles which we are discussing, which has a significant activity against zygomycosis and mucormycosis type of a infection, which are not getting treated with ketoconazole or itraconazole, but seconazole can treat such type of a fungal infection. So this is the added advantage of a seconazole. Now we are moving to the next category of the drug. Azoles are over, and we are moving to the next category of the drug, which are called as the echinocandins. The drug which fall under this category include casfofungin, micafungin, anidulafungin. Echinocandins are actually the newest class of antifungal drug. They comprise of 6 amino acids which are linked to the lipophilic side chain. All drugs which are based on the structure of the echinocandin B, they are found naturally in this type of a microorganism, which is nidulans, and they are active against found to be candida infection and aspergillus infection. Now if you look at the mechanism of action of the fungal of the echinocandin, then this diagram already I have shown you that this is the composition of a fungal cell wall, and we have seen the drugs which are inhibiting the ergosterol, like amphotericin was there, which was forming the pores across. Then there was azoles which were inhibiting this pathway of squalene to squalene epoxide to lanosterol and lanosterol to ergosterol. So this intermediate pathway, that is conversion of lanosterol to ergosterol, was getting inhibited by azoles. Now let us understand where echinocandins are working. You can see that there are the beta glucan synthase enzyme, which is causing the synthesis of this beta glucan. And as the synthesis takes place, this beta glucan gets added up into this cross-linking of the cell membrane. Now when cell wall. When this cross-linking of the cell wall, it gets added up, It gives strength to the cell wall. Now, echinocandins, can you see over here? There is a negative sign. Echinocandins inhibit this enzyme called as beta-glucan synthase enzyme. So what happens? The synthesis of this beta-glucan stops, as a result of which the cross-linking will stop, and that will create a damage to the cell wall. As the cell wall is damaged, that will lead to the death of the fungi. So this is a very simple mechanism by which echinocandins work. So they are inhibiting the synthesis of a beta-glucan in the fungal cell wall, and they lead to the disruption of a fungal cell wall and therefore leading to the cell death. So they are, if you look at the structure of the echinocandin, this is a structure, a very big structure and a complex structure is there. You can see this molecule is a cyclic and it is a lipopeptide antibiotic. And being a lipopeptide, it can dissolve easily into the cell wall. So after dissolving into the cell wall, it inhibits this enzyme beta-1,3-D glucan synthase enzyme. And therefore, there is a loss of the cell wall glucan, which results in the osmotic fragility. What are the different spectrums against which it acts? The candida, including non-albican isolate, which are generally found to be resistant to fluconazole, can be treated with this drug. Aspergillus, but it is not effective against other mold infection like Fusarium or zygomycosis, and it even doesn't cover the fungal infection of a cryptococcus. So in the resistant condition, echinocandin can work better. It is highly active against, you can see, all candida type of the infection. It is very active against aspergillus and various selective candida infection, whereas it has a limited activity against certain blastomycosis or histoplasmic or capsulatum type of a infection. Caspofungin, kinetics are, its absorption is less than 2%. Distribution is around 9.67 liter, that is a VD value. The protein binding is very highest, is around 97%. As I told you, it's a cyclic lipidopeptide. So it will undergo a peptide hydrolysis followed with a very slow acetylation at N-terminal. Its T-half is around 9 to 11 hours. It doesn't penetrate within the CNS. Obviously, the dose adjustment is required because it causes moderate to severe hepatic dysfunctioning. The dose adjustment will be required in those patients who are already suffering from the hepatic disorders like hepatitis or so on. Yeah, there are certain drug interactions, but they are not yet well established. Caspofungin acetate is the one which is given only by the IV route. It is given for invasive candidiasis, aspergillosis, which is or aspergillosis infection, which is resistant to the other antifungal drug. And these are the doses which are usually administered to the patient. Regarding the adverse effects of caspofungin, if it is given intravenously, it has been found to cause irritation. It sometimes even lead to certain antigen antibody reactions, therefore causing symptoms like fever, headache, flushing, erythema, or appearance of a rash. And that is usually because it causes release of histamine. Then sometimes these adverse reactions may be mild and they do not require any intensive treatment. Just the discontinuation of a drug will reverse the symptoms. It also causes elevation of a serum transaminase levels, but as such, clinically it has been found to be well tolerated by the patients. It is extremely well tolerated. There are minor GIT side effects, only that if it is given in combination with another drug, cyclosporine, it is found to elevate the liver enzymes, and only concern is that it causes release of histamine on IV administration, and therefore fever, chills, such type of the side effects may be observed with a caspofungin. Now we are moving to the next category of the drug, that is systemic antifungal drug, which are used for mucocutaneous infection. That means these drugs are given by systemic route and they are used to treat a skin infection, mucocutaneous infection. Griseofulvine is very insoluble drug. It is not soluble in the water. It is fungi-static drug. It is derived from the another fungi, that is a Penicillium griseofulva. It is being less soluble into the water. It has to be administered with a fatty meal, which induces formation of the micelles, and along with the micelle, the drug gets absorbed. It is active against most of the type of dermatophytic infection, epidermatophyton, trichophyton, microsporum. But it is not found to be effective against candida or any bacterial, where azoles are very effective, whereas griseofulvine is not effective against candida or bacterial infection, especially anaerobic. It gets deposited into a newly forming skin, where it binds to the keratin and protects the skin from the new infection. And another advantage is that it remains bound to the skin for very number of weeks. So even if you stop the administration of the drug, already administered drug will be present bound to the keratin layer. And it will take care and it will protect the new skin layer from getting infected with a fungal infection. How does it work? It interferes with the spindle formation in dividing fungal cells, and therefore it interferes with the mitosis. What does it do is that it causes abnormalities in the metaphase, but it doesn't arrest the metaphase. Now, because of which what happens is that because the spindles are, there is abnormality in the spindle, spindles do not recoil, so daughter nuclei don't separate, and that disorients the microtubules. And as the daughter nuclei don't separate, cytoplasm doesn't divide, and the multiplication of the fungi is stopped. So if you observe under the microscope the fungal growth in presence of griseofulvine, you will find that there are multinucleated stunted fungal hyphae are present. Because the hyphae are not able to multiply, they remain stunted, and since the nuclei don't depart from each other, they appear to be multinucleated. The griseofulvine is metabolized usually by a mechanism called as methylation mechanism in the body. Regarding its adverse effect, it is known to cause a photosensitivity. This is the drug which will lead to the inflammation of liver causing hepatitis. It cannot be given in the pregnant ladies as it is proven to be teratogenic, and it also causes inflammation of peripheral neuron, thereby causing peripheral neuritis. Another drug of the antifungal category and a recent drug which is there running into the market and very widely used for nowadays in a fungal infection is allylamines. And one of the type of allylamine is terbinafine. These are synthetic derivatives. They are orally active and are especially used for onychomycosis infection and for dermatophytosis infection. They are also used for keratophilic infection, and they are known. Griseofulvine is fungistatic, whereas terbinafine or allylamines are fungicidal in the nature. They interfere again with the synthesis of ergosterol. Even we have seen azoles are inhibiting the ergosterol synthesis, but they are preventing the conversion of lanosterol to the ergosterol. These are the ones which are inhibiting squalene epoxidase. So they are acting on the earlier pathway. And what happens is that when a squalene epoxidase is inhibited, the squalene doesn't get converted to its epoxide form, and that leads to the accumulation of a squalene. It interferes it doesn't interfere with P450, but it inhibits the enzyme squalene epoxidase, and that leads to the accumulation of a sterol squalene. And if there is accumulation of a sterol squalene, it proves to be a toxic to the fungi. Now we are moving to the next, that is a topical antifungal therapy. When we talk about a topical antifungal therapy, these are the antifungal drugs which are not given systemically, but they have to be applied topically in the form of cream, ointment, or dusting powders, and or suppositories. And their mechanism is similar to the amphotericin B. If you remember mechanism action of amphotericin B, it is not because why they need to be given topically, because they don't show a very good absorption. Not only that, but they have a very unpleasant taste, and therefore oral administration becomes very difficult. They are usually used for a local candidal infection, or even to treat oral fungal infection like oral pharyngeal thrush, even vaginal infection like vaginal candidiasis, and rarely they have any adverse effect. Another topical azoles are clotrimazole and miconazole. We have seen ketoconazole, which can be given both orally, systemically, fluconazole, which is given systemically. Now we are seeing those azoles which are given topically, which include clotrimazole and miconazole. They are used for vaginal candidiasis, oral thrush, dermatophytic infection, very commonly observed tinea corporis infection, tinea pedis and tinea cruris infections. Their absorption is negligible and that's why they have to be given by topical route. Comparatively adverse effects are less. They are even available in the form of a shampoos, where ketoconazole is also available, Nizral, which is a very good example of ketoconazole shampoo, which is majorly used for treatment of seborrheic dermatitis or pityriasis versicolor infections of our skin of the scalp. Then we are coming to the topical allylamines. The topical allylamines are the drugs like terbinafine and naftifine. Both are effective against the tinea cruris infection or tinea corporis infection. They are usually found across the nails, our toenails, where the nail coloration becomes yellow and gradually turns into a black. And such type of the fungal infections are very difficult to treat because there are very few drugs which can penetrate through the hard core of a nails. And terbinafine and naftifine are the drugs which can work at that sites. So they inhibit again the same mechanism. Squalene epoxidase leads to the accumulation of intracellular squalene, and there is a deficiency of ergosterol within the fungal cell wall, which ultimately leads to the death of the fungi. And then the terbinafine, why it is preferred for such nail infection, tinea infection, because it has an ability to concentrate in the skin, especially in the nail beds, and making it quite useful for those infections which are associated with nails. So we have seen now number of the drugs up till now. We have seen first that is amphotericin B and nystatin forming the aqueous pores and causing leakage of the intracellular material of the fungi and therefore leading to the death. We have seen azoles inhibiting lanosterol to ergosterol synthesis, and terbinafine type of the drug preventing conversion of squalene to squalene epoxide and therefore ergosterol synthesis. So both terbinafine and azoles ultimately interfering with ergosterol incorporation in the fungal cell wall. Even we have seen echinocandin which are inhibiting beta glucan synthase and therefore preventing this cross-linking of the cell wall. We have seen flucytosine which is interfering, which is acting as an anti-metabolite and preventing the multiplication of the fungal cell wall. Not fungal cell wall, fungi. So there are so many drugs of the antifungal which are available. We have even seen griseofulvin, which is interfering with mitotic spindles and preventing the departing of the it is causing irregularities in the metaphase and therefore preventing the division of a fungal cell. So all these drugs can be shown in a one diagram as it is shown over here, that amphotericin B and nystatin interfering with a fungal cell, then various azoles interfering with ergosterol, flucytosine interfering with the DNA replication, and griseofulvin interfering with the mitotic spindle formation. So this is how you can remember the various types of the antifungal drugs acting at a various sites within the fungi. So thank you.